Therapy-related acute lymphoblastic leukemia is rare, and the way we define it or think about it is the ALL that arises after genotoxic therapy for another condition. It's usually another malignancy. Patient receives either chemotherapy or radiation therapy for another malignancy, or perhaps an autoimmune disease which might be treated with agents that are genotoxic. So after receiving such treatments, we know that individuals are at risk for therapy-related leukemias. And what we have traditionally known and observed is that most of the time, if somebody develops a therapy-related leukemia, it is a myeloid neoplasm, such as MDS or AML. But in a smaller fraction of patients, we can actually see acute lymphoblastic leukemia that we can associate with the genotoxic therapy that they received. This is particularly common with certain therapies, and the main one is the Lenalidomide therapy that is used for multiple myeloma. When we look at therapy-related ALL and their prior genotoxic exposures, we will see that this entity is enriched for patients who have history of multiple myeloma. About 40% of therapy-related ALLs happen in multiple myeloma patients who are on long-term lenalidomide therapy. And these days, thankfully, myeloma patients live longer because we have several effective therapies, but the longer they live, more lenalidomide they receive, higher their risk for ALL becomes. And most of my therapy-related ALL cases in my practice now are post-myeloma. We don't know clearly how lenalidomide causes ALL. There are different thoughts behind that. Obviously, being an immunomodulatory agent, working through the cerebron and degradation, it depletes Ikaros. We know Ikaros is important for the pathogenesis of ALL. So, but the mechanism is still not fully worked out. One of the important things is about therapy-related ALL is that it has a higher risk presentation and usually inferior prognosis compared to ALL that arises de novo. And the reason for that is therapy-related ALL often presents with high-risk genetic mutations. Most often, we will see p53 mutations, and accompanying that, there will often be low hypodiploidy. So low hypodiploidy p53 mutations are high-risk features. Sometimes patients can have KMT2A MLL rearrangements, and oftentimes they might also present with what's called biphenotypic leukemia or mixed phenotype acute leukemia that has both B lineage markers and myeloid markers. We treat B myeloid MPAL just like ALL in the therapy-related leukemia setting, but these are some of the important points. These therapy-related ALL patients might not respond as well to the standard chemotherapy. Especially the MRD negativity rates are not as good as what we see in patients with de novo B-ALLs. So then the question is, should these patients be transplanted? At this moment, what we typically do is we base our decisions on MRD, but we also like to incorporate newer agents. We don't just treat them with standard chemotherapy. We like to introduce Blinatumomab. We like to introduce Inotuzumab. There are also several studies investigating these upfront, which enroll therapy-related ALL patients, and it seems like outcomes are better when patients receive these antibody-based therapies. So that's what we do. But a majority of these patients will likely have persistent MRD and might need to transplant.